That seems to work.
Hello.
Hey, cool.
Awesome. So you want to just try sharing your slides?
Yeah, let me just make sure I can
Yeah, just monkey around with it a little bit because you're gonna have to have it in presenter mode, and then
yeah, exactly.
you're
Can
gonna
you
want
I don't
the
want everyone getting sneak previews of everything. Can you just hang tight so I can make
oh,
sure
of
it
course.
works? Okay. All right. I feel like every time I do this I have to like remember how to do it, you know?
Yeah, the thing is like I go back and forth. Teams is easier to present from the VA, but
Yeah.
Zoom is easier to post from on post to YouTube.
Yeah, fair. Okay, let's see. So if I first go to presenter mode. Okay, maybe I have to share the screen first. What if I do this? This is going to show everything on my screen. Did that work or not? Are you seeing my notes or?
I can see your notes now, so you just have to do the view options and switch presenter mode for it. Just switch screens. There's a if you right click,
Oh, I see. How about now?
there you go.
Okay, so you can't see the notes anymore?
Notes, no notes.
Okay, cool.
Go ahead and change that also to say management of alcohol and benzodiazepine withdrawal
Mm-hmm.
uh, by David Veith, edited from previous work by
Sure.
Jonathan Wells.
Yeah.
Because this is yours. So
Fair enough. To be fair, I did
anything that
make
you
quite a few adjustments to it. Let me.
but the thing about it, David, is that anything you take and edit, you need to just own it as your primary material and just give me credit for previous stuff because um when you put it on your CV and stuff, you just
Mm-hmm.
want it to be you. And
Yeah. Yeah. No, that
when
makes
you
a lot of sense.
and doing editing of presentations, I understand how much effort and work. It's impossible to present other people's material. So it this is yours.
Okay, fair enough. I appreciate that. Um, Let me just make sure that I change both. Oh, of course, now it's updating PowerPoint.
Perfect timing.
Yeah, it's
We'll be
always
shutting
something.
down Microsoft Office
Yeah,
for
yeah.
maintenance.
Oh, yeah, my license expired for Microsoft Office. I'm joking. All right, cool. Well, I think this should work. I'm just going to do the same change on the, so I have it as two separate presentations. So I'll just change partway two. I feel like people probably need a break after an hour. Do you normally do a break or do you dive
Yeah, I
in?
usually do a break, read the room.
Yeah.
Um, you do whatever you want to do. Now that I know you can record it, so the main thing is, I'll just garbage this recording right now. It'll do another recording, and it automatically records the moment you start the
Okay.
presentation. So just let people. Everybody knows because they have to agree to your being recorded when they
Oh yeah.
come onto it. So you don't have to worry
Yep.
about that. And I'll edit this shit out later, but
Cool.
I'll still introduce you, but then I'm gonna bug out.
Okay. Sounds good to me. My PowerPoint is updating, but I assume it will be fine. Okay, it's
Yep.
back.
There you go.
Cool. All right.
Try it one more time. Just share.
Yeah, let me just modify this one. Because I feel like I have to start the share first and then go into presenter mode, which is kind of stupid, but
I think you do.
I'm gonna have to change it to the new screen after I do the presenter mode. So this should be showing you my notes. Oh, and it's doing this. So then, okay, is this the correct mode?
Yep.
Okay, and then if I change the slides, you're still just seeing the slides themselves?
Perfect.
Okay, sweet.
All right.
Yep.
Cool. I'll see you in about 10 minutes.
All right, sounds good. See you in a
Okay, bye.
bit. Bye.
Hello.
Let me know when you want me to start admitting people. So far, there's just Glenna Martin and Ramita Goel.
Cool. Go ahead and start. Hi, Ramita. Hi, Glenna.
Hello. Hello.
Hello. How was children's, Ramita?
Children's is good. I am following up with one patient named Koda. She is like a Ewing sarcoma patient and like, you know, dependent on now hydromorphine IV. So we were planning to start on like subnoxone or like she is low like use disorder patient and we are
Yep.
managing her. So Brenda
He
was sick
has
and
complex opioid use
yeah,
disorder, chronic
yes,
pain associated with real pain, which is cancerous, and she abuses the opioids too.
yes.
Yeah.
So
Yeah, well, they're lucky to have you there. I'll definitely be available for questions. Those are tough cases.
yes, we were discussing to connect with you. Hopefully to connect also by tomorrow if we get another call.
We can touch base tomorrow, or we can touch base later today. Hey,
Okay.
Taylor. Hey, Mike.
Hey, how's it going?
Good, good. Well, I've been better personally, but
It's so reflexive. Good, good. Yeah.
Oh no,
yeah,
I'm sorry.
everything's wonderful.
Yeah, great, fantastic, perfect. Yeah.
So usually we'll give it a couple more minutes before we start. David's got a lot of material to get through, so I'll introduce him here in a second, and then I'm going to bounce off.
Sounds good.
Hi, Lena. Hey, Bill.
Hello, how are you?
I've been better, man.
Yeah.
So I'm going to go ahead and introduce. Hey, Laura. I really appreciate everybody's coming today. I'm going to introduce Dr. David Veith, who's going to, thank God, be presenting today. I have had a horrible week of tooth and facial abscess that is like a ridiculous story, which I will not bore you with right now, but I am very happy that Dr. V is here to take over. He is a former fellow of ours in the addiction psychiatry fellowship. He was a University of Washington medical student and then went to Columbia for his psychiatry training. We're lucky to have him working at the VA on our consultation and inpatient service. You'll all work with him when you rotate with us on inpatient at the VA. And without further ado, I'm going to pass it on to him really appreciate your attention. Again, I'll upload these videos and then send you a reminder link for next week where we will present another topic. All right,
Awesome.
take it away, David.
All right, thanks, Jonathan. Hey, rest up and feel better. We'll try to calculate your COWS score when you leave, but we'll work on it.
Hopefully, I will not be on opioids long enough to develop one. Yeah.
All right, sounds good. Take it easy. Thanks.
Yeah.
All right, can you guys all see my screen? All right, great. So hey, nice to meet all of you. You can just call me David. You'll rotate with me at some point at the VA, doubtlessly. So this is going to be a marathon of didactic today. So it's going to be on alcohol, both withdrawal and also relapse prevention. It's a lot of material to go through. I'm going to go at a pretty fast pace. Please feel free to stop me if something isn't clear. So anything that we don't totally cover in the allotted time today, we'll end up covering in the like kind of bonus section that Jonathan saves for the end of the didactic series. So feel free to stop me if anything's not clear, but just prepare yourself because it is going to be a lot of information and we will take a break partway through, okay? So without further ado, let's dive into it. So the first part of our lecture today, we're going to talk about how you actually manage folks who are going through alcohol or benzo withdrawal. Just know that this presentation was initially started by Jonathan and I modified it pretty heavily. All right, let's see here. Okay. So our goals for this presentation are, one, to be able to triage patients to the appropriate level of care based on their history and their presentation. Two, to be able to choose a strategy for which benzodiazepine medications that we want to use when we're actually treating the alcohol withdrawal. Three, we'll also discuss a little bit some of the non-benzo options for treating alcohol withdrawal. I also want to spend some time talking about Wernicke's encephalopathy, which is a really important consideration with these patients. And then we're going to spend a little bit of time talking about how we actually taper patients off of benzos. So the first question we need to ask ourselves, even before we talk about how we assist a patient go through withdrawal, is detoxification even indicated for this patient? So when you work with me and with Jonathan here at the VA, you're going to be rotating through our 7 West inpatient psychiatric unit, what we call Team 3, which is our voluntary, basically withdrawal unit. And before we even consider how we're going to take care of withdrawal, we need to think about if it's even indicated for the patient. So the main things that you want to consider are whether the patient plans to continue treatment for the substance use disorder after the detox process. The detox process itself, especially when we're talking about alcohol with benzos, is not harmless. It comes with its own risks. Mike can tell you about a patient that we took care of last week who actually developed what looks like potentially DTs. So it's not a harmless process. We want to make sure it's worth the while of the patient. So detox alone is not recommended when we're treating alcohol use disorder, but it can be part of their overall recovery if they're planning on continuing to do some treatment afterwards. If a patient's not planning to aim for sobriety and they don't intend to continue treatment of the alcohol use disorder after going through detox, we're generally not going to be recommending that they go through voluntary detox. We'll find some other way to engage them, but we're not going to put them through the rigors of detoxification. All right, so let's spend a little bit of time talking about the actual pharmacology of detoxification. Can one of you guys just tell me verbally, can you see my mouse when I move it on the screen?
Yes.
Okay, thanks. So in the top left here, we can see what's kind of like for a typical person who's not physically dependent on alcohol or benzos. We can review that their main inhibitory neurotransmitter GABA is balanced by their main excitatory neurotransmitter, which is glutamate, and they exist in homeostasis. So next, we see what happens when we ingest alcohol or when we take a benzodiazepine such as Xanax. We're tipping the scales towards GABA, and this is what happens when patients get disinhibited or sedated, basically when they're intoxicated. So over time, the body adjusts by reducing the amount of intrinsic GABA that we have, and also by increasing the amount of glutaminergic tone. So I'm an alumni of using Sketchy Micro, so I like to use kind of visual mnemonics and representations here. So for glutaminergic tone, I'm using an amplifier to represent this has been amplified, and also to help you to remember that it's AMPA is one of the main receptors for glutamate that we're thinking about. So that's one of the main receptors that's actually getting modified and upregulated here. So this is what happens when a patient adapts to using a lot of alcohol or a lot of GABAergic medication. They have this balance where they have less GABA intrinsically and more glutamate. So then what happens in the withdrawal state is you lose the exogenous form of GABA, you're left with your reduced GABAergic tone, and you have an excess of glutamate. So you can see the scale here is tipped towards that amplifier, and they're in a hyper excitatory state. So I want you guys to think of alcohol withdrawal as being extra excitation. So when you think of someone who's tremulous, it's like extra movement. When they're hallucinating, that's essentially, you know, that they're having extra perception experiences. And then also when they're anxious, it's like having extra anxiety. So this is kind of a good representation of what's actually happening when someone is going through withdrawal and what we actually have to correct with medication. Okay. So the DSM-5 criteria for withdrawal requires that the patient reduces or ceases using alcohol after a period of heavy or prolonged drinking, and you really only need 2 or more of the following symptoms. So that's autonomic hyperactivity, so a sweating or pulse rate greater than 100. As Mike could tell you, we saw an interesting case last week where the pulse never went above 100. You see increased hand tremor, insomnia, nausea, vomiting. Some transient visual, tactile, or auditory hallucinations are also illusions, psychomotor agitation, anxiety, and in more severe cases, you can see generalized tonic-clonic seizures. The part C of the criteria is included on all of our psychiatric diagnoses. It's basically just saying, hey, there's not a better explanation for these things. Okay, so let's talk about complicated alcohol withdrawal. So whenever you hear an addiction specialist talk about complicated or complex alcohol withdrawal, it's basically an umbrella term that encompasses a few really bad outcomes that we're trying to avoid. So those outcomes and what's encompassed in this terminology are seizures, delirium tremens, and alcoholic hallucinosis. So keep in mind that alcoholic hallucinosis is actually not at all synonymous with delirium tremens. So delirium tremens, by definition, the patient has autonomic dysfunction and changes in sensorium, and to put it simply, they're delirious. So this contrasts quite a bit with the patient with alcoholic hallucinosis, who will be able to tell you like, hey doc, I know this is really weird, but I'm looking out my window, you know, from my hospital bed, and I can see elephants outside, and I know the circus isn't in town. That's more of a story of alcoholic hallucinosis, versus the patient with DTs might think they're actually in the circus, or they might think it's 1955 or something like that. And also that aspect of you're going to see autonomic instability. The seizures themselves are in some ways related to the development of delirium tremens. So it's not a direct connection, but patients who do have a seizure are thought of as having a higher risk of developing DTs subsequently. One of the things I really like to teach in terms of mnemonics is how we can remember the timeline for these complicated withdrawal symptoms. Because as you can imagine, this can be really helpful if you're seeing a patient in the ED and you're trying to figure out where kind of on this spectrum are they falling. So the way I remember this is for seizures, I remember sixtures. So think that they can peak kind of in the first 6 hours. They're actually an early sign that the patient's developing complicated alcohol withdrawal. For alcoholic hallucinosis, my mnemonic for that is to think AH, which is about half. So it's around 12 hours, half a day. This graph's a little bit off. I would shift this a bit to the left. Hallucinosis you typically will see in the first day if it's going to happen. And then continuing with the mnemonic, we have DTs, so delirium tremens, DT, day 2, 48 hours is when you see this peak. So we think of this as being a later complication that can happen with withdrawal. 48 to 96 hours when you might expect DTs to develop. So if a patient shows up in the ED and they just started withdrawing recently, and you have a really good history about when their withdrawal started, and they're presenting as delirious, don't hang your hat on delirium tremens because that timeline doesn't actually make sense. So that's one of the reasons why it's important to actually really, you know, have a good sense of the timing of these things. So let's talk a little bit more about delirium tremens. So, you know, it's the reason why we bring this up and why we're concerned about it, and more concerned about it than even with maybe a garden variety delirium that you might see from another cause, is essentially that it's really, really deadly. So 30 years ago, before we really were a little more sophisticated in our treatment of delirium tremens, it had a mortality rate of like 30%. So almost 1 in 3 patients who developed this were passing away from it. Nowadays, hey, it's still really significant. It's 1% of patients are going to pass away from it. And the cause of death in these patients is really from this underlying autonomic instability. They're getting hyperthermic, they're having cardiac arrhythmias. If they're developing seizures simultaneously, they can have complications from that. So really think of it as like their autonomic system is going haywire here. In terms of predictors of mortality for patients who already have developed DTs, a couple to keep in mind are one, persistent hyperthermia. I think that's pretty self-explanatory that if you're persistently hyperthermic, you're headed the wrong way. The next one is actually the use of restraints, which is interesting. So the way I would think about the use of restraints as being an indicator in DTs that a patient's at a higher risk of mortality is not that the restraints themselves are killing the patient or that they're going into rhabdo necessarily from fighting against the restraints, but rather it's probably an indirect marker that the patient's being inadequately sedated by their medication regimen. So that's how I would view the use of restraints as being associated with mortality in delirium tremens. Okay, so now we have a sense of what outcomes we're really trying to avoid. Let's start to talk a little bit about how we actually triage patients. So one of the really cool things you guys are all going to get to do in your fellowship is actually consider doing an outpatient detox. So, I can only speak for myself as a recent graduate from the fellowship, but I had never even come close to attempting something like this through, my training in medical school nor in residency. But it really is possible. It's something that you can try to do. I would put it this way. There's a really high bar that has to be passed before you're going to recommend that a patient go home with some benzos and try to do a detox at home. So let's talk about some of the criteria, some of the things that you're going to have the patient have to jump through in order to do an outpatient detox. So the first consideration I want to highlight is that the patient really has to have an ability to get to clinic on a daily basis. So if they are living out in like a really rural area, you don't want this detox going haywire and them not having an ability to come in and be seen by you. Secondly, you want to make sure that there's someone supportive there to help them. So actually what you'll usually do if you attempt this during your fellowship is have this supportive person join you for this last appointment and really teach both the patient and the supportive person, hey, this is going to be the taper of the benzodiazepines that the patient's going to be on. Let's like actually put the tablets into bags. Let's label them. Let's make sure you can teach back to me how you're going to go through this taper. And this is, of course, really logical, right? So if the patient started to develop any sort of complicated withdrawal, or if they're getting delirious, or if they had a seizure, you want someone there to be able to call 911 or to be able to reach out to your office and check in with you. Going down our list, so you want to make sure that they've only had a history of really mild or moderate withdrawal. If there's any prior history of delirium tremens or withdrawal seizures, which I've highlighted here in red, I would basically say this is a complete no-go for ever considering doing an outpatient detoxification. There are some sources that say that, hey, under special circumstances, like let's say a patient only relapsed recently and they're using way less alcohol than usual, and they recently went through detox and it was not so bad, that maybe you could consider an outpatient detox. If you want to ask me, I'd say don't even consider it. That the second you hear there's anything resembling DTs or seizures, you're just throwing outpatient detox out the window, and you're already kind of planning how you're going to bring the patient in for inpatient detoxification. The next factor to think about is if the patient's having any amount of SI or HI, or if they have an underlying psychotic condition. This is just an indication that behaviorally, when they go through the stress of detox, there's a potential that they could harm themselves or harm another person. So you're thinking that they want to be in a supportive environment. And actually, this might be an indication that not just should they be inpatient, but they should actually be on a psychiatric unit. For co-occurring medical conditions, the basic idea here is you want your patient to be really, a kind of a picture of health. before you're attempting to do the outpatient detox. So if they have really like poorly managed diabetes or even hypertension, or if they were pregnant, don't consider outpatient detox. You want them to be in a supervised environment where you can really keep a close eye on them. If a patient has had severe alcohol withdrawal in the past, even if it hasn't gotten to the point of DTs or withdrawal seizures, I'd say err on the side of bringing them in. If they're going through withdrawal of multiple substances, like you will very commonly see patients who are using alcohol and opioids when you work in the ATC, that gets really complicated, bring them into the hospital. And then this goes without saying, but if they're not going to be able to keep themselves hydrated or even to eat regularly, you're not going to consider outpatient. So basically, the takeaway here is have a really high bar before you decide to do an outpatient detox, but it is possible, and I do recommend that you try to find an opportunity to do it during your fellowship. I'm going to skip this next slide here. So this is a really ugly, disgusting flow chart that we use here at the VA, and that you're going to have some version of this imprinted in your mind by the time you're done with fellowship. So basically, this is a flow chart that we use at the VA to help us to make decisions about where a patient should go. It's a little overwhelming. I still refer to it frequently, when I'm making decisions about triage. What I'm going to end up doing at the end of this lecture is sending you guys my slides. You can take a little time to look at this. But this is kind of a nice systematic way to work your way through, hey, where might I want to send a patient? Like if I were seeing them in the ED or in a clinic, they're either already withdrawing or they're about to withdraw. Where do I want them to go? Like, do they need to go to the emergency department? Do they need to be admitted? So I'll send this along to you guys. This is one local, like site-specific flowchart that we've used to determine level of care. It's going to be different at different facilities, but this at least gives you a little bit of a sense of what will be going through your mind by the end of fellowship when you're triaging patients. So this graph will be you in only a year's time. Okay, so now we've decided that we've admitted the patient, we're gonna do detoxification, it's indicated, they're motivated, they wanna do treatment. So let's actually start talking about some of the medications that we can use to help them get through the withdrawal. So the mainstay of treatment is going to be benzodiazepines, as you all know. So all of these work by binding to GABA A. And the mnemonic I remember for this is, hey, we're treating alcohol withdrawal, we're using the GABA A receptor. So let's walk through these and talk about their different properties and the ones that you should be familiar with. So the two that are most commonly used are chlorodiazepoxide, which is a mouthful, and I'm going to call it Librium from here on out, and lorazepam, which is Ativan. It's a little easier to say. So Librium is a long-lasting benzodiazepine. It's metabolized by the liver into several active metabolites, as we'll see in a second. Ativan, which is our other favorite, is not short-acting, so you will hear people refer to it as short-acting. It's actually intermediate. It's only short compared to some of the longer acting ones. And what we like about it in certain circumstances is that it has a quicker onset of action, it lasts for an intermediate time, and it doesn't have any active metabolites after it's metabolized by the liver. I also want to spend a little bit of time talking about the other two. So diazepam, I would think of as working quite a bit like Librium. So it's long lasting, it has active metabolites. Where it differs from Librium is that it's a lot more lipophilic. So the significance of the fact that it's lipophilic is that it very quickly gets through the blood-brain barrier. So this can be really useful if you need to get really quick control of withdrawal that's quickly going out of control. But also keep in mind that this also makes it a little bit more rewarding for patients. If you're going to have a patient on diazepam as kind of a long-term medication, perhaps a little bit higher risk of abuse, because it quickly gets into the brain and can be very rewarding. The other flip side of it being lipophilic is that it can get into fatty tissues and it can kind of slowly leach out. So of all the ones we're talking about, this is the one where I might be a little concerned for iatrogenic delirium. We actually recently had a patient on 7 West who we were giving diazepam to actually to help him with stimulant withdrawal, and he got pretty delirious from it and needed to go actually to internal medicine. So diazepam, keep in mind, it can really stack up, and part of that's because of the lipophilicity. Oxazepam plays a little bit more, oxazepam plays a little bit more like lorazepam. So this is, again, kind of a more intermediate length. It does not have active metabolites. I personally have never used it, but it's possible that you may, because there actually are times when there are shortages of lorazepam, and if you wanted a more intermediate acting medication without active metabolites, you might want to turn to oxazepam. I personally haven't had to do that, but it is possible. So this graph just kind of represents what we're talking about here when I mention metabolites from the longer lasting medications. So everything here with an asterisk is metabolically active. The one that's missing it but is active is lorazepam. But let's take a look together at chlordiazepoxide again, which is Librium. So you can see that every single thing produced as it goes through each step of hepatic metabolization is active and is having an effect on the patient. So each of these metabolites is helping to treat the withdrawal, but also potentially contributing to delirium, right? So in a lot of cases, the fact that you have a longer lasting medication with active metabolites is really positive. But if you're worried about the function of the liver, it's easy to see how each step in this process, like each of these arrows, could potentially get backed up, and you'd have a buildup of this one and this one and this one, and that this could stack and cause the patient to either get overly sedated or to become delirious, have respiratory depression, have a fall, etc. You can then contrast that with oxazepam and lorazepam, which you can see basically get conjugated once by the liver and they're excreted. So there's nothing active, and they're going to be inert, and it's kind of more an easy on, easy off because of that property. Okay. So in general, when you're selecting a benzo, you should know that there's no perfect benzodiazepine. So it's not like you should have one default benzo that outperforms all the rest and you need to talk yourself into the other ones. That's absolutely not the case. So if you actually look at the data, Cochrane had a really nice meta-analysis at their usual very high standards where they looked at the 4 benzodiazepines that we just discussed, and they found that all 4 of them were efficacious at treating alcohol withdrawal. If anything, there was only a slight but potentially very real benefit for chlordiazepoxide in preventing complex withdrawal. But this is slight, so not really significant. So basically, what we learned from this is just when you're making a decision about which benzodiazepine you want to treat for a patient's alcohol withdrawal, base it off those properties that we just discussed. So think about if the patient's liver is functioning well, or if you're concerned that the active metabolites are going to stack up, or think about if they have a history of really bad complex withdrawal. So I'll give you an example of where you might want to consider using a long-lasting medication. You know, if you're working in a facility where the nursing staff perhaps is a little less skilled, or they're a little less used to doing regular CWAs, and you're concerned actually that, hey, they could miss doing a CWA, or they can underscore a patient, you may want to err on the side of choosing a longer lasting medication, so you know that if something gets missed, they're still going to have something active on board. So again, takeaway here, there's no best benzo, and err on the side of choosing the one that has the best properties for the patient that you're taking care of. So now that we've talked about the different benzos, let's talk about how we actually dose them. So there are 2 schools of thought here for how we could dose patients with benzodiazepines. The old school way of doing this was just a fixed regimen. So this is just like any other medication you're ordering in the hospital that's not a PRN. You're giving it at some certain time interval, maybe with a hold parameter for oversedation or respiratory depression. This is really actually how alcohol withdrawal used to primarily be treated. The other alternative is to use a CWA, or what's called a symptom-triggered regimen. So this is what I imagine most of you are more familiar with. And in my training before doing fellowship, this is really all that I had used exclusively. So of course, with a CWA triggered regimen, it's essentially saying that when a patient scores above a predetermined threshold, usually it's a score above 9, then they're going to get medication and they're going to be reassessed in an hour and potentially get some more medication. So the question is, which of these strategies is better? And for this, there actually is a little bit of a clear answer. And the answer to that is, in general, a CWA or symptom triggered regimen is preferred. So there's a seminal study that you guys will actually review at some point later in the fellowship, where they did basically like a head-to-head comparison. I think they used Valium, and they compared patients who were just given fixed doses versus patients who got symptom triggered. And what they found basically was that both regimens were equally efficacious at treating the underlying alcohol withdrawal, but the patients with the CWA triggered or the symptom triggered regimen got a total of less medication. So they didn't need as many benzos. And as a result, they're less likely to have complications of benzos. So less likely to get overly sedated, less likely to get iatrogenically delirious, less likely to have respiratory depression, etc. So basically, we learned from this really great seminal study that you can get away with less medication and less side effects by doing a CWA or symptom triggered regimen as opposed to the old school way of doing a fixed dose regimen. That's not at all to say, though, that we've forgotten about doing a fixed dose. So there's definitely a time and a place for that. And that time and place is if you've decided that your risk reward scale is really tipped towards needing to avoid complicated alcohol withdrawal. So if you're taking care of a patient and they very routinely go into complicated alcohol withdrawal, they get DTs or they frequently have seizures, you need to err on the side of getting more medication in them. So in those cases, you do want to err on the side of at least giving them a day's worth of fixed dose medication. So again, this is going to be a little site specific, but what we do on our unit at the VA and what works really successfully is that for these patients where we're concerned about their risk of complicated withdrawal, we'll do 24 hours where they're going to get 50 milligrams of Librium every 6 hours around the clock, only being held if there was concern that they were getting overly sedated. And we found that this sort of treatment plan where you're giving them medication around the clock really helps to prevent their development of complicated withdrawal. But again, if you're taking care of a different patient who's never had complicated withdrawal, they've only ever had mild to moderate withdrawal, they're otherwise healthy, then your risk benefit analysis is going to be tipped towards wanting to avoid putting them into delirium from the medication itself or wanting to avoid a fall. So in that case, you want to go with the CWA driven regimen because it's going to expose them to less medication. Okay. Okay, so that's a lot about benzos. Let's start to change gears here a little bit and talk about some of the non-benzo medications that we can use to take care of these patients. So the one that you need to know about the most of the non-benzos is phenobarbital. So phenobarbital, of course, is a barbiturate. So a few key things to remember about this. So if we go back to our little our diagram of what happened with folks who have a neuroadaptation and have become dependent on alcohol, remember that there are two things that change, right? So they have less intrinsic GABA and they have more intrinsic glutamate. When we treat patients with benzodiazepines, like all the four we just discussed, we're actually only fixing one of the two issues here. So when we give someone benzos, we're just doing GABA A. Remember, it's GABA A for alcohol. But we're actually ignoring the fact that they've had this change with their glutamatergic tone. So they're hyperexcitatory in part because they're having too much glutamate. So what's unique about phenobarbital and what contrasts it with all the benzos is that it does double duty. So as you all know, barbiturates are also helping us to get GABA, but they're actually also reducing some of that glutamatergic tone. So that's why I've X'd out the amplifier here. And this is thought to be the reason why phenobarbital in particular is so effective for these kind of refractory cases. So let's talk a little bit about the history of phenobarbital. So I'm not that much older than all of you, but when I was training and doing residency, we essentially never used it. It was thought of as being this really old school, kind of barbaric medication. For the longest time in the earlier 1900s, 1950s, it was the go-to medication, and it was used really successfully. The problem with phenobarbital is that back then, when it was first being used, it was really being used in too high of doses. So folks were getting uh, doses that was measured in grams rather than milligrams, essentially. And unlike with benzodiazepines, there's no reversal agent like flumazenil. So if someone gets really overly sedated from a barbiturate, your really only option is to intubate them. You can't reverse anything. Um, so for a long time, phenobarbital actually fell out of vogue and benzos kind of reigned supreme. We're right now in the midst of what I would call the phenobarbital renaissance. So phenobarb has very much come back into the forefront of our minds when we're taking care of these patients. And part of that is because of this paper that came out in 2012 by an author, Kawasaki, who was based at Johns Hopkins, where he was actually looking at how can we use phenobarbital in a fixed dose regimen to take care of patients who are going through benzodiazepine withdrawal. And as we'll touch on later, benzodiazepine withdrawal is essentially the exact same as alcohol withdrawal. And so what they did in this seminal study in 2012 is they took 310 patients. Some of them actually did have a history of complicated withdrawal from benzos or alcohol. So, quite a few of them were also on opioids. And they basically just did a fixed dose regimen. So they gave them 200 milligrams for one dose, then 100 milligrams Q4 for 5 hours, then 60 Q4 for 4, then 60 Q8 for 3. And they actually did this without a CWA, and they just held doses if the patients were getting overly sedated. And the results were essentially fantastic. So none of the patients had seizures. 3 of them did get delirious. That's not that many when you're considering the fact that these were really sick patients. And 53 of them did leave AMA. You might consider that's because they were actually feeling well enough to leave and were able to leave. So basically, the historical precedent here is that this paper in 2012 really brought phenobarbital back into vogue. There's a lot of different ways to dose phenobarbital. When you rotate with me and with Jonathan, you will get an opportunity to. We actually had a patient on phenobarbital in our unit just last week, and you're going to find that it's really site specific. So Harborview has its own protocol. Utah Montlake kind of has their own protocol, but there are several different ways you can do it, both using like a modified version of this fixed dose, and you can even get a little bit creative and do kind of a CWA-driven regimen with it too. But the big picture here is you should know that phenobarbital is doing 2 things. It's helping with GABA, it's helping with glutamate, and it's really effective for refractory cases. So let's talk about how benzos and phenobarbital can interact with each other.
Okay.
So, right off the bat, it sounds, it would be pretty clear that phenobarbital is adding to GABA tone, right? It's a GABA agonist, and that could contribute to, affecting the subsequent doses of benzos that you give to a patient. And this is true. So when you give someone phenobarbital, it's really long lasting, it's constantly agonizing GABA, and you're giving them back some of that GABA tone. It also has another kind of unique property, which is that it the way it binds to the GABA receptor actually potentiates each subsequent dose of benzodiazepine that a patient receives afterwards. So when a patient has received phenobarbital, if you later switch them onto a CWA-driven regimen with Ativan, each of those doses of Ativan is going to be like oversized or more effective than it would be otherwise. And this combination of using phenobarbital in combination with benzos has been studied and shown to be like really effective. So there's actually a study out of UCSF where they found that using some variety of this combination helped to reduce the ICU admission rate. And for patients who were already in the ICU, it reduced the amount that needed to be put on mechanical ventilation. So takeaway here, phenobarbital is really effective, and it can actually play well with benzos, but keep in mind it can make the effect of the benzos stronger. But we really like using phenobarbital in these cases that are where patients appear to have resistance to benzodiazepine when you're trying to treat this really refractory and really kind of severe alcohol withdrawal. Because it does have this interaction with benzos, that can be a little less predictable. So you may find yourself having to adjust the CWA afterwards. Like maybe instead of receiving 2 milligrams right off the bat, you'd want them receiving 1.5 or 1 milligram, something like that. And then also keep in mind, this is obviously very relevant for our patients, that phenobarbital is hepatically metabolized. So if their liver is not doing well, you do have to be concerned that it can build up quite a bit in these folks. Okay.
Hey, David, can I ask one question real quick?
Of course.
So I had a patient in the ICU at one point who was going through complex withdrawal, and it was on a phenobarbital course. And it was like at 24 hours and he was still going through complex withdrawal, and we had to change him to something else. But it seemed like there was like a ceiling, like 25 milligrams per kilograms or something within 24 hours. Could you speak to that a little bit? Because it seems like there's a threshold of how much can be used in a given time without toxic effects.
Yeah, totally. So there very much is a ceiling effect, and there are like site-specific determinations about when you've reached that. What I'll send you after this that's really interesting is MGH has come up with a really kind of cool protocol where they help you determine like a weight-based loading dose and also like how you can check serum levels. So basically, with regards to your patient, there are some patients who need more than phenobarbital. And at that point, you're talking about putting them on a dexamethasone, basically, right? Is that what happened with your patient? Yeah. So is that similar to what happened?
Yeah, that's exactly what happened. And
Yeah.
Nurse was like, "This is great. Thank you for doing that."
Yeah. So you can actually graduate beyond phenobarbital. What's nice about phenobarb though is you can really dose people heavily and you can follow serum levels. But in a case like the one you're describing, yeah, you graduate onto that next medication. So that's basically what happens. And when you hit that threshold is going to be determined based on the site that you're working at. And I'll be honest with you, working at the VA and primarily taking care of patients on inpatient psychiatry, we're not doing a lot of stuff where the folks are intubated. So normally at that point, we're handing it off to our ICU colleagues. But yeah, absolutely, you can graduate past phenobarb. Okay. So let's keep going. So we started talking about the benzos. We talked about phenobarb, which is our barbiturate of choice. Let's keep going kind of even deeper away from our benzo mainstays here. So let's talk about the non-benzos, non-barbiturates, and what role they have, if any, in treating folks who are going through alcohol withdrawal. To cut to the chase here, I basically want you to know that Cochrane, again, our gold standard here, said that there's insufficient evidence to support the use of any of the following medications we're going to talk about in treating alcohol withdrawal. So you can go ahead and look at their systematic review, their meta-analysis. I'll also put a little caveat here, which is that if you completely relied on what Cochrane review endorses, you'd be left with like 5 medications because they just have like such a high standard for anything. So none of these medications are going to meet this kind of gold standard Cochrane review level, but there are some cases where they can be useful. And since this is like an advanced level course, let's actually review those cases because they're going to be relevant for us. Okay. So the first pair that I want to talk about is carbamazepine and oxcarbazepine. So these work by potentiating GABA. They're also felt to work like a lot of the anticonvulsants do by inhibiting voltage-gated sodium channels. So there was a systematic review that was done in 2010. It had a total of 612 patients. They generally found that it was safe and tolerable, these medications. For these patients, they didn't see a difference in DT or seizures. Humongous asterisk here is that most of the patients included in this study were excluded if they had had a history of complicated withdrawal. So I would not be encouraging you to use this medication if anyone had a history of complicated withdrawal. It's not going to be a mainstay, but there are some times when it can be a little helpful and it can be safe. Does anyone want to chime in with what gives us a headache as psychiatrists about carbamazepine? I'm just curious if folks want to mention why we don't often use it, even if it's sometimes helpful for bipolar or for things like this, alcohol withdrawal.
Isn't there a risk of like dermatological side effects?
So that's true. The main reason why we don't use it, Mike,
Granulocytosis is also like uh, blood cells, they decrease like granulocytes, carbamazepine.
so all this is true. This is a little bit of like read my mind. So carbamazepine has way too many side effects. That's very true. It also has way too many drug-drug interactions. So if you guys remember my psychiatry colleagues among us, this is the medication that induces its own metabolization, right? So you get someone on carbamazepine, they're doing great. It induces its own liver enzymes to begin metabolizing itself. And I feel like this just captures in a nutshell what a headache this medication is. It interacts with itself. It also interacts with everything else. So that's one of the reasons why we don't use it very often is chances are it's going to interact with something else that the patient is taking, okay? Gabapentin, so very different story here. So gabapentin actually has some compelling evidence, and you guys will review some papers over the course of the fellowship, that it can be really effective in cases of really mild or moderate withdrawal. Never use it as a mono agent with severe symptoms, but it can work really well if someone is, for example, meeting this threshold of being able to do an outpatient detox. So one of the things that's nice about gabapentin, if you have a patient who you know they've never had severe alcohol withdrawal, they only ever have mild withdrawal, you can actually totally do an outpatient taper with gabapentin alone. So it works really well for these cases. The other nice thing about it is that one of the risks for doing an outpatient detox is, gosh, what if your patient keeps drinking alcohol when you send them home with the benzodiazepines? I've had this happen before. This is another reason why you want to have a supportive person there to kind of make sure that they're not using alcohol while taking Valium or something, right? If this were to happen, a lot safer for it to happen with gabapentin than with the benzos. So actually, for some patients who you want to do an outpatient detox on, if you feel safe because they've never had anything beyond mild or very low end kind of moderate alcohol withdrawal, give gabapentin a go. You can even give them a little bit of like breakthrough benzo in case something happened. But gabapentin is a good option for this, and there actually is good evidence that it's helpful for folks who are going through withdrawal. And it's very, very safe. We like it a lot in psychiatry because it's essentially impossible to overdose on as a mono agent. Okay, so the takeaway here for our non-benzo agents are that carbamazepine and gabapentin are the only two that you guys should really have in mind. They do have some evidence of being efficacious and they can be safe. If a patient's ever had severe alcohol withdrawal, complicated alcohol withdrawal, forget about using either of these as a mono agent. You can use them as an adjunctive. So actually, I think, Mike, we've had some patients where our recommendation has been, hey, in addition to doing a benzo CWA regimen, let's maximize this person's home gabapentin at the same time. So we'll get them on like scheduled gabapentin 600, TID, get a little benefit from that. And then they're also on CWA. And we feel like this is probably sparing them a little bit from the extra benzodiazepines. So carbamazepine, gabapentin, they both have their role. They are effective. Carbamazepine gives us as physicians a headache because it interacts with everything. And I didn't even mention the other anti-epileptics because I actually don't want them to stick in your guys' mind. There's no evidence to support the other ones. So these are the only two that you should think about. But really, again, mainstays, benzos, and phenobarb. And these are kind of your alternative agents that in certain cases can be helpful. So this is kind of our really rapid fire review of alcohol withdrawal. I'm going to start talking about some related subjects in a moment, but any questions before we transition?
Yeah, I had a question for benzos.
Mhm.
Like when would you typically use oxazepam before clonazepam or alprazolam, even though maybe those benzos could work too, or have you used those ones?
Yeah. So my theory that I can tell you guys about, because Jonathan's not here, is I'm not convinced that oxazepam really exists, and I think that it's only listed in books as an alternative agent for patients with hepatic impairment, because I've never seen anyone use it. So to answer your question, I would basically never choose oxazepam over either Librium, Valium, or Ativan. It's never really used, but you should know that it's effective and it's available. And there are periodic shortages of Ativan, but there would be no reason to choose oxazepam over Ativan if they were both available to you. Does that answer your question, Stephanie?
Can you use like clonazepam or alprazolam?
So you'll never use them, and I don't think they've been as widely studied. Like that Cochrane review wasn't looking at that. Theoretically, you could, but I really can't think of a reason why you would want to use them. It seems like, if I remember correctly, clonazepam I don't think has active metabolites. I think it's long lasting, like in and of itself, and it's definitely not as lipophilic as Valium, as diazepam is. You're not getting that benefit. So to answer your question, you'll never use clonazepam for alcohol withdrawal. You're almost exclusively going to use chlordiazepoxide and Ativan. And then there may be some cases where you use diazepam kind of next, but you'll never use clonazepam, and only theoretically would you turn to oxazepam. Okay.
Okay. And I guess like say I had a patient, or I've had a lot of patients with alcohol use disorder who I inherited, or also like taking PRN clonazepam or something like that.
Sure. Yeah.
Ideal to switch agents if for whatever.
Yeah, I think because, we're just in general less familiar with the use of clonazepam. Like, let's say you have a patient like that and you felt kind of brave and you want to do an outpatient detox. I would say get them onto something we know works really well, like Valium first, like do the equivalent dosing and then attempt it with that. So yeah, there really aren't circumstances where you would use clonazepam to detox folks. And as an outpatient, it's exclusively going to be probably Valium, Ativan, or Librium. Okay. Yeah, a good question. Okay, so let's move on to a related subject. This is Wernicke encephalopathy. So I just wanted to add this kind of at the tail end of our discussion of alcohol withdrawal, because it comes up so often and it's something I always want you guys to have in the back of your mind. So the biggest disservice we do, when we're teaching folks about Wernicke encephalopathy in medical school and also in residency, is it gets hammered home that this thing is a triad. So if you think back on your like step 1 studying, I'm sure you remember that it's taught as a triad with confusion, ophthalmoplegia, and ataxia. And that's kind of what you remember, and those are the key things you look for in your multiple choice question. So the truth is, it's really, really rare to see all 3 of those things. The gold standard way to diagnose Wernicke encephalopathy is an autopsy. I don't recommend that you try to order this when you're working on our service, but this is the only way to actually know if the patient had the mammillary body degeneration at the end of the day, because it can be missed on imaging, right? So imaging isn't the gold standard, it's actually autopsy. And when we use autopsy studies, what we see is that patients who had some signs of Wernicke encephalopathy but didn't have the full triad were being missed. And this is not like an insignificant amount. So actually some of these studies are showing that 80% of patients who probably had Wernicke encephalopathy were missed and were not given this diagnosis during their lifetime. And this is a catastrophe, because Wernicke encephalopathy is direct damage to the brain that can become permanent. And of course, at that point, we call it Korsakoff syndrome. So what I want you guys to take away from this, not just for yourselves, but also as educators when you're working on a consult service, is get people to forget to look for the triad and teach them about the Kane criteria. So again, going back to my background with a sketchy micro, this is my kind of visual mnemonic for you guys. So it's a candy cane and it's a 2. And this is to help you remember that the Kane criteria, you only need 2 out of 4 things. And if you have those 2 out of 4 things, you're empirically going to treat the patient as though they have Wernicke's encephalopathy, unless you have a really compelling explanation otherwise. So those 4 things are dietary deficiencies, oculomotor abnormalities, cerebellar dysfunction, and altered mental status. And altered mental status does not need to mean full-blown, like they're completely delirious, even though that can often be the case. It can be kind of subtle changes in their memory, their cognition. My point here is I want you guys to have a super, super low bar, a very, very low threshold to say, hey, this could be Wernicke's. I want this person to get on a bunch of thiamine. The reason for this is that if we miss Wernicke's, it's catastrophic. It can cause permanent impairment in the patient's functioning. And the treatment for Wernicke's encephalopathy is so benign. We're just talking about giving someone a high dose of thiamine. So, you know, as far as how we actually treat this, there's a couple different regimens that you should be familiar with. The first one's the Royal College of Physicians, and they basically say 500 milligrams IV TID for 3 days. And then, you know, if they're responding and doing well, you can kind of work down to 250 and continue that for 5 more days. The other one that you should know about is the European Federation. They use a regimen of just 200 milligrams IV TID, and they say continue until symptoms resolve. I'll tell you guys what we do here at the VA and what I kind of learned from Jonathan, which is that we do 500 milligrams TID, and you want to do this preferably IV, because, well, actually, I'll ask you guys, you know why we don't just make this PO? Because that sure would be a lot easier than having to get an IV on someone. Does anyone know why we don't do a PO? No? Okay, so, or Stephanie, I saw you unmute, so I'm gonna call on you. Do you know?
There's like a legit reason, or just because the patient maybe can't tolerate PO.
Yeah, I mean, that's definitely a good thought. The basic idea is that PO absorption in a thiamine is just really poor. So they're not actually going to get a lot of the thiamine that they're taking. And especially if the patient, and we're talking about folks using alcohol, has been using alcohol, they may have disrupted their mucosa in their GI system, and they might not be absorbing vitamins well to begin with. The reason also, you know, I've had this come up before when I've taught this lecture. Folks ask, well, why don't we just check a thiamine level, right? And if the thiamine level is normal, then we can feel reassured. And the reason for that is that what we actually care about is the thiamine level in the person's brain and in their CNS, right? So when we check someone's serum level, that can actually fluctuate. You know, they had a big meal earlier in the day, and that serum level could be misleadingly normal or even high. So that's why we don't bother with thiamine levels when we're making this diagnosis, and it's not one of the 4 criteria. So again, takeaway here, have the lowest bar to treat someone because you're potentially gambling with their cognitive functioning for the rest of their life, and the treatment is super safe. If you're on an inpatient psychiatric unit, and Mike has seen this before, and you're in one of these situations where, like, gosh, you know, I don't think this is Wernicke's, but there's enough here that I want to err on the side of treatment. Well, then you're in a little bit of a bind because we can't actually do IV medications on inpatient psychiatric units. So the next best thing that we can do is actually dose this IM. So IM is still a heck of a lot better than PO in terms of absorption. I'll usually tell the patient that they're just going to get some free like acupuncture a few times a day, and usually they'll like laugh it off and agree to that. Sometimes not so much, but usually that works pretty well. But big picture here, you can't rely on PO. Have the lowest bar to pass to call this empiric Wernicke's and treat them. Okay. Any questions about Wernicke's? No, we're good. Cool. All right. So let's conclude this first part just by talking about benzodiazepine withdrawal. So benzo withdrawal, clinically, it's essentially indistinguishable from alcohol withdrawal. So that also comes along with the risk of complicated withdrawal. So actually the worst case of delirium tremens that I've seen as an attending was one that I saw with Jonathan. It was a patient who didn't drink alcohol. It was someone who obtained Xanax, like illicit powdered Xanax from the street, and then went into horrible benzodiazepine withdrawal with clear delirium tremens, and it had everyone perplexed for a little bit because they, were not drinking and people were wondering why this delirium had developed. So it's clinically essentially indistinguishable. When you're trying to determine the patient's risk of going into benzo withdrawal, if they were to have abrupt cessation, you're kind of thinking in a similar way with alcohol withdrawal in terms of, hey, how long have they been using benzos? What's the dose of the benzo that they've been using? What distinguishes it from alcohol is that all alcohol, for the most part, is being metabolized the same way. But with benzos, of course, we're talking about different substances. We spent all this time at the beginning of the lecture talking about how different benzos get metabolized differently. And what we're concerned about here, right, is that if they're using an actual kind of shorter acting benzo like alprazolam, that they're more likely to kind of go into withdrawal. It has no active metabolites and it goes off really quickly. So the type of benzo actually matters when you're trying to determine someone's kind of overall risk. So even though clinically this looks really similar to alcohol withdrawal, the treatment decision tree in terms of how do we, treat this patient who's dependent on benzos is actually really quite different. And the reason for that is that in clinical practice, we're usually not recommending that patients who are dependent on benzos go through an actual detox the way that we do with patients who use alcohol. So it's really rare that we'll have someone come in for like a planned detox off of benzos on our unit here. And the reason for this is it just seems like this does not set up these patients well at all for success. There's, I think, some theory behind other, neurochemical adaptations that occur in these patients. But essentially what you see is that folks who've been on benzos for years and years often get this like rip-roaring, intractable anxiety that occurs even after you've taken care of the acute withdrawal period. So you can detox someone off of the benzodiazepine, but they're going to be a nervous wreck going forwards. So typically it just doesn't work so well if you try to kind of rip the Band-Aid off the way you would with alcohol. So usually what we're going to recommend for these patients, as opposed to an acute kind of admission to do detox, is a super slow, super long, and very flexible patient-centered taper over the order of weeks, months, or gosh, even years. So generally what this is going to look like is if you have a patient who's using something kind of shorter or intermediate lasting, like for example, alprazolam or lorazepam, is you get them on something longer lasting. The kind of gold standard is diazepam. And then you very, very slowly reduce the diazepam dose over weeks, months, or years. And I was telling Mike this just the other day, but you'll inherit some patients during the fellowship on your outpatient panel, probably that I've seen. And, that each contribution, each wave of fellows knocks like 1 milligram of Valium off of this patient, over the course of every few months. And that's really what it looks like for these folks. So you're very, very slowly taking them off of the medication. You may have to pause the taper if, like, let's say they're going through a rough patch, like the anniversary of a loved one's death, or the holidays are coming up, or something like that. You may slow the taper or stop it completely. And you're basically kind of meeting the patient where it's at. And as you are able to, taking a milligram off here or there and kind of helping them get through this period and giving them time to adjust in terms of their anxiety. During these long, slow tapers, this is where you're going to want to use things like SSRIs to help with kind of rebound anxiety that the patient experiences. But anyways, takeaway for benzos, the actual withdrawal, essentially identical to alcohol. The actual treatment decision tree is really different, okay? So look, this is the first half of our lecture. Why don't we pause here? Do you guys have any questions on this before we take let's say like a 5-minute break? Any questions on detox, benzos, tapers?
Oh, I just had a question about the benzo tapering that you just mentioned. They usually use diazepam, and I was curious about that. I have a couple patients on my panel, as you stated, who have inherited extraordinarily slow tapers, and they're all on clonazepam. So I don't know if that's just like practice pattern difference or if you have a particular reason for diazepam instead.
Yeah, so both of them are totally acceptable options. They're both long lasting. I think it often comes down to kind of patient preference. In my own experience, I found that a lot of patients, especially the ones who are dependent already on kind of on like alprazolam and things that have a really kind of high lipophilicity and quick on, are not going to tolerate clonazepam as well because they're just kind of used to that experience of getting kind of like the quick reward. But clonazepam is totally useful. I'll correct myself a little bit. I think clonazepam and diazepam are the two that you're going to see used frequently. My own kind of bias is that I've seen some folks where we've converted them from shorter intermediate lasting agents onto clonazepam and seen them not tolerate clonazepam, but I've seen them tolerate the equivalent dose of diazepam. And I think that has to do with just the lipophilicity. But to correct myself, either option, clonazepam or diazepam, is going to be useful. And those are the two that you'll really see.
Okay.
Yeah, awesome. Any other questions? Okay. Well, look, why don't we take a 5-minute break? So like, let's reconvene at 3:10 and we'll continue our story. So now that we've detoxed our patient, let's talk about how we help them to stay abstinent. Okay. So let's return in 5 minutes.
Hey, David.
Uh-huh.
Hey, hey, I'm at the ATC right now, and I'm sending a guy that did not do well on his outpatient detox to the inpatient unit. And the more you're talking about it, I mean, he's been like the last 2 times I saw him, he's just like, he can't remember anything. Then again, his blood alcohol levels 374 when he went to the ED.
Uh-huh.
But certainly somebody that like the more like he's affected by homelessness, so I would say dietary issues would be an issue. So I mean, quite honestly, he's like somebody who's going to you would want to treat for this. I just want to make sure that I'm doing him right. I don't want him to get up to the unit there and we're not going to be able to do anything about that. So I don't have to talk about it right now, but just wondering, like, is that still somebody that's going to be appropriate to come to 7 West, or should we be doing something else?
Yeah. So you're basically saying, are you concerned that he may have some kind of Wernicke-Korsakoff?
Yeah. I mean, the only thing I didn't notice any like ophthalmoplegia or anything weird like that, but he certainly keeps saying, I just can't remember, like having cognition issues. Like,
yeah, I mean, I would, so, 2 things that come to mind, absolutely send him to us. So that would not be a reason for him to come to be with us.
Right.
One of the things that I didn't dive into as much with this, but that you really see clinically, is folks can develop Korsakoff and they can also get like a superimposed Wernicke on top of it.
Okay.
So there are these folks, I know, right? So there are these folks who have this kind of like more kind of permanent neurologic change that's consistent with Korsakoff, but they can still actually have improvement if you give them repletion of thiamine. So this is something that we like, if this guy's going to come onto the unit, we'll absolutely take a look at him, for this. I would say with this gentleman, I would think with him about this, like the kind of just 2 out of the 4 criteria, right? It sounds like he would probably meet it.
Right.
If you think he's nutritionally deficient and has had cognitive changes.
Yeah.
So, when he arrives on the unit, we'll probably treat him empirically if he was looking that way. One really clever thing I've seen someone do who wanted to just check to see if there was any visual changes. Are you doing like phone appointments, or is this guy coming in?
Yeah, he came in originally. And again, that really wasn't on my radar because it was my original intake with him and I just didn't see anything like that.
Yeah.
In the last appointment, he was wandering around downtown because his truck/home had been towed. So,
oh gosh,
yeah.
So I mean, you know, this is the sort of guy where we'd probably empirically treat him. One
Yep.
thing I've seen someone do during like a kind of typical ATC phone appointment was you can ask about double vision too, to
That's
pick
good.
up on ophthalmoplegia. Or so you can ask about diplopia. Hey, are you seeing double? You can ask them if they look to the side, are they seeing, you know, multiple versions of something?
Great, great,
So,
great. Yeah.
but again, you know, this is someone who we probably would just empirically treat. And even though Korsakoff is thought of as being this permanent thing, they can still actually get better if there's some superimposed Wernicke on top of it.
Sounds good. Well, yeah, once they get a inpatient date scheduled for him, I'll look and see either who the fellow or who the attending is going to be, and like let them know that it would be probably most appropriate just to treat and empirically, and then we can go from there.
Yeah, totally. Just always feel free to reach out and give us a heads up. And
Okay.
we very much like to kind of coordinate these things. So any advance notice is great.
All right, that sounds great. All right.
Cool.
I'm sorry, I didn't mean to.
Oh, no worries. I'm going to
5
step
minutes.
away for a second, but I'll be back in a moment. Okay. So why don't we reconvene? Here, I'll put in the chat. Actually, is there a chat? right, so whenever you guys are back, just turn on your cameras at least briefly, so I know folks are ready to go. Can you guys see the slideshow? And is it in the correct view? You're not seeing the presenter notes, right? Okay, good. No
Yep,
spoilers.
it's in the correct view.
Okay, good. All right. So let's see if we can fit this in. We have 45 minutes. It's going to be a bit of a marathon. I think we can do it though. So we finished talking about withdrawal. Let's talk about how we keep our patients abstinent afterwards. All right. So again, this is an adaptation of some work that Jonathan started that I have made my own. Oh wait, let's see. Is this? Okay. Did the slides change for you guys? You see the first slide, this is FDA approved medication. Okay, cool. All right. So the bulk of this lecture that we're about to start is going to be focused on the 3 FDA approved medications for relapse prevention, which are disulfiram, naltrexone, and acamprosate. We're also going to spend a little bit of time talking about medications that are used off-label, but that demonstrate some evidence or some promise. And spoiler, this is primarily gabapentin. Finally, because this is an advanced level topic, we're going to review some of the more esoteric off-label medications that don't have quite the robust evidence base that some of our other meds do, but that are used occasionally. And let's dive right into our first FDA approved medication, which is disulfiram. So let's start with a history lesson, kind of like we did for phenobarbital, because this is interesting. So this is the chemical structure of disulfiram. It was first discovered in the late 1800s, and back then it was called tetraethylthiuram disulfide. I recommend you don't call it this with any of your patients. So basically, its first use was discovered in the rubber making process. It's during the sulfur vulcanization process. And in a rubber factory here in the United States in the early 1900s, like literally 1900, one of the factory doctors taking care of the workers made this observation that some of the workers seemed to be getting sick when they would go to the bars after working in the rubber factory all day. Absolutely nothing came out of this observation, but it was seen really early on. In the 1940s in Europe, they started trying disulfiram as a treatment for parasites like scabies and intestinal worms. And during this trial period in Europe, a group of test subjects who were taking the disulfiram to see if it would kill their intestinal worms had a similar thing where they went home and they drank after trying their medication and got super sick. And once again, this got completely missed and nothing like clinical came from it. So it wasn't until like 5 years after this European trial when a Danish drug company executive made an offhanded comment to a buddy of his who was a physician about this observation that finally something happened with this medication. So it just so happened that this doctor happened to specialize in treating patients who had alcohol use disorder. And he perked up when he heard his buddy, who's a European drug executive, say that these workers or these test subjects got sick. And it wasn't until 1948, so almost 70 years after this medication was invented, and almost half a century after the first observations of its interactions with alcohol were seen, that it started to get described in clinical literature. So let's review the pharmacology here. So this should be a review from step 1, but basically remember that disulfiram works by interfering with aldehyde dehydrogenase, ALDH, and this leads up to a buildup of acetaldehyde, and that's what causes the really uncomfortable and notable side physical effects that we'll go through in just a moment. But again, since you guys are at a more advanced level, we're going to go beyond just talking about its effect on ALDH, and we're going to talk about another important but lesser known effect of disulfiram. All right, so this is another process that disulfiram actually interacts with. So ALDH is not the only target of disulfiram. So it also is a dopamine beta hydroxylase inhibitor. So this is an enzyme that inhibits, or rather that converts dopamine into norepinephrine. So disulfiram also inhibits this process, and as a result is thought to raise kind of baseline dopamine levels. So this is why you'll see in some literature that there's some indications that disulfiram might be helpful in taking care of patients who use cocaine. It's because it's interacting with this process of dopamine in the brain and potentially raising baseline levels of dopamine, which is thought to reduce cravings to use stimulants or cocaine, and maybe even could be a little bit aversive. So maybe if your kind of dopamine levels are a little high, the extra cocaine is not going to feel quite as good. This is a little hand wavy, but it's thought to be why there's some evidence for this. The reason why I included this in this lecture, besides the fact that you guys are advanced, is that cocaine use disorder and alcohol use disorder are often really comorbid. So it's like important to know that there's this medication out there that might be helpful for both of them. I'm gonna query you guys. Does anyone know the chemical that is created when you use cocaine and alcohol at the same time? A psychoactive chemical. This is for like tons of extra credit. And if no one knows, it's great, because then I get to teach you a fun fact. Okay, so this is one for you guys to whip out when you're on consults and you're talking to a primary team for a patient taking both cocaine and alcohol. So the two of them, when they're ingested together, combine into something called cokethylene. You can look this up on your own time, but it's basically like a longer lasting, more cardiotoxic version of cocaine. And some people speculate this might be why there's so much comorbidity between the two. So anyways, fun facts aside, just remember that disulfiram is useful in cocaine use disorder in addition to alcohol use disorder. Okay, so let's talk about the use of disulfiram for alcohol use disorder by reviewing the disulfiram alcohol reaction, as it's called. So again, remember that this is from a buildup of acetaldehyde. The typical symptoms that you see are flushing, sweating, nausea, vomiting, headache, tachycardia, hypotension, dyspnea. The patients are going to feel like crap, to put it lightly. The severity can vary quite a bit, and that's kind of dependent on what dose of disulfiram the patient's taking, and also how much alcohol they ingest while they're taking the disulfiram. Note that this reaction can be more than just uncomfortable. It can actually be dangerous for patients. So there is some literature indicating that folks who have a really severe reaction, usually with kind of underlying medical comorbidities, can have respiratory depression, cardiovascular collapse, arrhythmias, they can develop seizures, they can have an exacerbation of CHF, and folks can potentially die. So these are all things that you need to talk about when you're doing informed consent with the patient. And you need to be able to tell the patient, hey, this is what the typical reaction's like. If things start to move beyond this reaction, gosh, we want you coming in, being seen in the emergency department. Okay. All right. So let's talk about the pharmacokinetics. So disulfiram super rapidly absorbed. It peaks pretty quickly. And note this is interesting. So its half-life is short. And this might lead you to think, well, gosh, if the patient is abstinent from the disulfiram for like only a little over a day, maybe they could get away with drinking. It's not the case, actually, not the case at all. So once this builds up and gets into people's bodily tissues, people can have the disulfiram reaction days or even weeks after they stop taking the disulfiram. You're going to want to use this to your advantage as a clinician when you're educating the patient. I want you guys emphasizing to them the unpredictable nature of disulfiram. The reason for this is you want the patient to have in the back of their mind the knowledge that even if they have kind of a momentary kind of lapse in judgment and it's been a week or so since they've stopped using the antabuse, they still have that potential for the reaction. So it's important for them to know this because first of all, they could get really sick. And secondly, that might be what it takes for them to not return to using alcohol, right? So when you're actually doing informed consent with patients on this is kind of where, in addition to being honest and truthful, it's okay to kind of play up be on the kind of longer end of the spectrum. Hey, this could happen 2 weeks afterwards. There are some kind of creative uses that you guys might see with antabuse when you rotate with me and with Jonathan. So sometimes we'll have really weird cases like a patient is supposed to go to residential treatment, but for a variety of reasons, there's going to be a gap in between when they get discharged from detoxing with us and when they go. And this might be a case where you want to dose someone with antabuse, like while they're here in the hospital with us, and send them home with some, but give them like a few doses before they go and let them know, hey, you're gonna have this reaction and you're covered for this kind of weekend long gap before you go to residential treatment. So we actually had a patient who unfortunately couldn't go to residential treatment because he developed COVID. So he has to wait for a little bit before going. And we offered him antabuse. He declined it because he has his dad to keep a close eye on him, but this is a situation where you might consider using it. So we talked about the disulfiram reaction, but let's talk about side effects. So again, this is separate from the reaction. These are just side effects of the medication. The most important one that you want to know is that there is a significant risk of hepatotoxicity. So we always kind of hammer home, hepatotoxicity and naltrexone. As we're going to see later, that's really not very significant. Disulfiram is the one where you really have to be on top of monitoring someone's LFTs after you start them on it. So usually the recommendation is at least 6 months of some amount of monitoring their LFTs. You're also going to want to educate the patient on the signs and symptoms of liver injury. So you're going to want to teach them, hey, if you're getting nauseous, you're vomiting, abdominal pain, malaise, fever, jaundice, this might be an indication that you need to come in and we have to check your LFTs and make sure things are going okay. Another side effect we're thinking about is in rare cases, it's thought that disulfiram can cause psychosis. The reason for this might go back to that interaction it has with dopamine. I don't think it's entirely clear, but we know that it raises dopamine levels, so there could be association there. Let's talk about contraindications. So I'll start by just telling you guys the medical kind of contraindications. So if you're talking about a really medically kind of tenuous patient at baseline, like they have really severe myocardial disease, they have coronary artery, occlusion going on, really unstable, brittle diabetes, they already have really bad hepatic disease, they have a seizure disorder, this is not the medication for them. You don't want them to like immediately die if they have the disulfiram reaction. On a kind of different note, a different consideration, can you guys think of any behavioral, or I'll kind of give away the lead here, but cognitive characteristics of patients that might set them up to not do so well with disulfiram? It's a little bit of like read my mind, but anyone want to throw anything out there for maybe someone who, if you're thinking about the way they're thinking, they might not be a good case for disulfiram?
Maybe suicidal ideation.
Yeah, I mean, I would agree with that. The other big one you want to think about as a contraindication is cognitive impairment. So you Bill, you were telling me about your patient whose memory is terrible. You don't want him forgetting that he's taking antabuse, right? So this is not uncommon that our patients have cognitive impairment. This is not the medication that you want for them, okay? Let me see your time here. Okay. So you're going to hear a lot of mixed things about disulfiram, and I bet you guys already have. Have any of you guys ever actually prescribed it? I'm curious. Anyone? Nope. Nope. What have you heard about it? I mean, it's one of the 3 FDA approved medications, right? It's kind of interesting that none of you prescribed it.
I've had patients that it was prescribed on the inpatient unit, and then nobody ever wants to take it, or they're told
Sure.
help, but they don't want to take it.
Yeah.
Yeah, I feel like it's like the naltrexone of alcohol use disorder, but like like it's almost punishing, and so patients are turned off from that.
Oh, totally. So this is the one where when you're talking to patients about naltrexone, they'll be like, that's not the one that makes me sick, right? You need to tell them that. what you'll hear from a lot of physicians, though, is that disulfiram's not effective. So you'll hear this a lot, or that there's not good evidence for it. And I included this slide because this is actually a really interesting point about how we think of disulfiram. So if you look at treatment guidelines, which you should, for how we treat alcohol use disorder, you're going to see a lot of recommendations that disulfiram should be thought of as at best a second line treatment, potentially third, or completely forget about it. So the American Psychiatric Association actually really plainly states that it should be a second line treatment, and they don't routinely recommend its use because, in their words, the strength of the evidence is low because there's not a lot of double-blind, randomized, controlled trials looking into disulfiram. And so basically, because of the lack of quality evidence, it's been kind of relegated to this kind of second tier of treatments, despite the fact that it has an FDA approval. And so it's actually kind of interesting is it's really underutilized in part because of this supposed lack of evidence. There actually was a complete halt in the production of Antabuse from September 2019 to August 2020. And it basically was off the market for this time. And guys, we only have 3 FDA approved medications for alcohol use disorder. One of them disappeared for a year. And I bet none of you knew that that happened. Versus, like, imagine the amount of coverage the Adderall shortage got in the last couple years, right? So, you know, it's really interesting how this is one of the medications that has an approval, but it's not used frequently. And the reason why it's not used frequently, in part, is because patients often don't want to use it, but also because people have a lot of doubts about the evidence behind it. But this raises a really interesting question. So the question is, should we even be thinking about disulfiram as a medication? Like, are we actually using the pharmacologic property of disulfiram to treat the patient? And I would actually posit that no, we're not. So disulfiram is really a behavioral intervention more than a medication. So it's the threat of getting sick that is going to have the patient potentially not use alcohol. So arguably, the effects of it are the behavioral effects of taking this medication that can cause the reaction. So there was actually a really interesting editorial in the Journal of Addictions that came out this past year that said we shouldn't be holding it to this same standard in terms of double-blind, randomized, controlled trials that we use for most medications. We don't hold interventions like cognitive behavioral therapy, which is a behavioral intervention, to that same standard. We don't hold, let's say, contingency management, which is the poster child for behavioral interventions, that standard. You can imagine with contingency management, they're not saying, oh yeah, some of you are going to be randomized to get some money if you're abstinent. The rest of you are going to get monopoly money if you're abstinent. Like, that just wouldn't make sense and it wouldn't work. So actually, if you broaden the pool of data that you look at for disulfiram and you look at open label studies, you can actually see a really interesting trend, which is that it can have a really large effect size that can actually outweigh some of the other medications we're talking about. So again, if you think of it as a behavioral intervention and you look at more data, then you actually see that, hey, there may be some efficacy here. So there was actually a meta-analysis where they looked at where they included open label trials, and they found that this had one of the biggest effect sizes of any medication. Of course, you could make an argument, hey, there's some self-selection going on here because patients are maybe a little more motivated if they're taking to begin with. But my point is, be a little thoughtful of how you think of the medication, and remember that it is really kind of more behavioral than a direct pharmacologic effect of the medicine itself. Okay. I'm going to skip this in the interest in time, but the takeaway is there was an interesting study where they prescribed people either 250 milligrams of disulfiram, which is an active dose, 1 milligram, which is inactive, or they gave them a vitamin. So the patients who got a vitamin, they knew they got a vitamin. The patients who got any amount of Antabuse knew that they got Antabuse, but they were not told if they got enough that was effective or they got 1 milligram, which is ineffective. So this was basically controlling for the behavioral threat of having the Antabuse potentially making you sick. And what they saw in this study was a significant reduction in the group that was taking antabuse. But again, this is open, right? So the patients knew they were getting antabuse, and this sort of information is not getting included in meta-analyses if they're excluding anything that's open label. So again, we just got to be flexible when we think about antabuse. There are some patients who could potentially really benefit from it. Okay. So let's simplify things a little bit and talk about a medication that is a lot less philosophically interesting, and that's naltrexone. So naltrexone is our next FDA-approved medication. My guess is that all of you have had some experience prescribing it before, and if you haven't, you will in the next week because we use it all the time. It's a lot more straightforward and easy to prescribe than the other two FDA-approved medications. So a few facts about it: it's rapidly absorbed. It has an active metabolite that has a much longer half-life, which is why even though the naltrexone itself has a short half-life, it has an active kind of period of over a day, we think of. We typically dose it at 50 milligrams, but you can go beyond this. So I've seen patients go on, up to 150. They tolerate it well, and that's the dose that it takes to reduce their cravings. And again, as you guys know, it's a mu opioid antagonist, so it interferes with some of the kind of rewarding properties of alcohol and reduces cravings. All right. One clinical pearl that I want to put in here, as you guys begin working in your outpatient clinics, is naltrexone is such a good medication to get like a foot in the door for patients. So you'll work with a lot of patients who, despite drinking or using a lot of substances, are going to have a lot of misgivings about medications, like some valid and some maybe a little exaggerated. Naltrexone is really nice because you can offer it to patients as like, hey, let's just see how this does. So take this as needed on days when you drink more, like, okay, every Sunday you get wasted when the Seahawks are playing. Just try taking this on Sunday, and let's see if this can reduce the amount that you drink on Sunday. And basically, because it has this kind of flexibility and you can dose it PRN and patients can notice some benefit, and usually it's really well tolerated, this can be a really good way to kind of get your foot in the door and get them engaged with treatment and get them on board with the idea of trying a medication and seeing that they can tolerate it. Okay, so briefly, let's review the data and explain why we prescribe it. This is a meta-analysis from 2005. To cut to the chase here, if you look at the subtotal for all the studies they included here, which were hundreds of patients, it showed a significantly lower relative risk in terms of returning to heavy drinking or relapsing in general. So there's a lot of strong evidence for this when we look at pooled analyses. Let's also talk a little bit about Vivitrol. So Vivitrol is one that we really love here at the VA. It's really effective. To go through it quickly, it only comes in one dose, which is 380 milligrams. It's given in a gluteal injection. There is really strong data for this medication. So there was a randomized controlled trial in JAMA. They looked at 624 patients. It was held to that standard that we don't hold disulfiram to, so double-blind, placebo-controlled, randomized, and all the patients received a psychosocial intervention called Brenda simultaneously, and they either got a low-dose injection of Vivitrol, the full robust dose, or a placebo injection. And to quickly go through this, basically every patient, compared to baseline, had a reduction in heavy drinking days, but there was a clear, dose-dependent effect where the patients who received the full dose of the extended release naltrexone had a clear reduction in their heavy drinking days. So this is a 48% reduction compared to the folks who got the placebo. And even the folks who got the lower dose, which by the way does not exist, is not something you can order, had a benefit. So we saw a really clear benefit in reducing heavy drinking days, which was the primary endpoint of this study. They also did a few secondary endpoints, which aren't included here, but they saw a reduction in risky drinking days, which was more than 2 drinks per day for a man, or more than 1 drink per day for women, and also saw a reduction in any drinking days at all. So this graph represents a reduction in heavy drinking days, but you see an across the board benefit in terms of time returning to relapse, any days drinking, risky drinking, you name it, you see a benefit. What I actually think is a little funny about this study is that in terms of negative side effects, the most common one was like local site irritation, and actually the placebo had a higher rate of that than either of the two active meds. So you can let them know, hey, this is really well tolerated. Like the placebo did worse in terms of tolerability. So basically, we love Vivitrol. It's one of our favorite medications. It's really effective. The other thing I want you to know is that for the patients included in this study, and they followed them for quite a while, there was no evidence of hepatotoxicity. I want you guys to know this for naltrexone in general. The association between naltrexone and liver damage is extremely, extremely overstated. You guys should have a really high bar to not prescribe naltrexone because someone is having an issue with their liver. I'm talking about like they're in the midst of decompensated cirrhosis and you think any one thing is going to push them over the edge. So in general, and you can check like, for example, clinical stat pearls, things like that, less than 1% of patients are going to experience any amount of changes in their transaminases with the doses of naltrexone that we use, both PO or IM. Usually these bumps in transaminases don't go beyond 3 times the upper limit of normal. They're self-resolving even if you continue the medication, and they're just not clinically relevant. You might wonder why, gosh, if any version of naltrexone is going to damage the liver, I'd be concerned about giving someone 380 milligrams IM. Like that sounds kind of more significant or severe, but actually this is the safest version for someone's liver, and you can educate teams on this when you're consulted. So the reason why the IM version is so safe is that it skips first pass metabolism. So it's not going through your mouth, it's not going straight to your liver, and it's exposing the liver to lower levels. You can also think that, hey, this is actually a lower kind of monthly dose than if someone was taking PO. So it's 380 milligrams spread out over a month as opposed to 50. But the takeaway here, and the thing I want you to remember, is don't get too concerned about naltrexone interacting with the liver. It's really disulfiram that you want to keep a close eye on. Okay, so we have 18 minutes. Let's see if we can get through it. So a few other reasons why we like naltrexone, besides the fact that it's really effective and it has flexible dosing and comes in an IM form, is that you can combine it really nicely with the other medications that we like to use. So one combination that's really good to know about is combining naltrexone with gabapentin. So there are some studies that show that the two of them together have additional benefits that either one doesn't have alone. So this is a graph from a paper that came out in 2011. They looked at 150 patients and they detoxed them, and they started them either on placebo, naltrexone, or naltrexone and gabapentin. And that's the green, the combination. And what you see is that for these 6 weeks, these are the folks who perform the best. They did some endpoint analyses and found that the folks who got naltrexone and gabapentin had significant improvement in the quality of their sleep. And this is strongly associated with returning to use. So folks who detox and don't sleep well afterwards, it's really putting them at risk of return to use. And we'll talk in a little bit in the gabapentin section about how this can help us here. But the takeaway here is know that naltrexone and gabapentin play together really nicely. You can get a good benefit from the two of them together. Okay, they're both well tolerated too. Okay, so another combination to be aware of, it's particularly relevant when you're taking care of patients with psychiatric comorbidity, is naltrexone pairs really nicely with antidepressants like sertraline. So this is a 2009 study. They looked at 170 patients. These were patients who met DSM-5 criteria for major depressive disorder and alcohol use disorder. They randomized them to get sertraline, naltrexone, a combination, or a placebo. Every patient got weekly CBT, so the placebo patients were not left high and dry. They were getting evidence-based treatment. But just quickly, so if you look at the blue kind of dotted line, this is the combination group, and you can just see that they had a statistically higher absence rate and a longer delay before relapsing to heavy drinking, which was the major endpoint that they looked at. What's not reflected here, but what's really interesting, is that the patients in the combination group, even though they were receiving the same amount of sertraline, 200 milligrams, as the other groups, fared better. So even though they didn't get a higher dose of antidepressant, this combination of naltrexone and sertraline not only helped them with drinking outcomes, but also depression outcomes. We might speculate that this could be because of the influence of return to drinking on mood. We know that alcohol can really potentiate and worsen folks' depressions if they have a tendency towards that. So I know this is rapid fire, so I'm trying to fit it all in. Any questions about naltrexone before we move on to our next and last FDA-approved medication?
So now, does naltrexone does work PRN, or if someone takes it one day, you'd expect perhaps they drink less?
So to my knowledge, there's not a lot of good evidence in terms of, the high bar that we hold evidence to for looking at PRN. So I'm going to give you my clinical experience, which, is the lowest and worst form of evidence, but it seems like it helps. Like in my clinical experience, when you talk to patients, I've met with many patients who find it helpful to take PRN on days when they think they're going to be at higher risk of drinking. And again, it's kind of this idea that like this may be a good way to kind of get them to the point where maybe they'll see that they tolerate it. We can think about daily dosing where we do have like evidence for it. Does that answer your question, Stephanie?
Yes, thanks.
Okay, great. So we'll move along to acamprosate. So this is our final FDA-approved medication. This one's used much less commonly. I personally never prescribed it until I did my fellowship. So I didn't get any experience with this until I was a fellow, but it's a good medication. So let's talk about how it works. It's a positive allosteric modulator at GABA A. So it increases the effects of our intrinsic GABA. So remember, go back to my kind of sketchy, little balance beam. Remember that if you're dependent on alcohol, you have a reduction in the amount of your intrinsic GABA. So this helps to fix some of that. So your GABA that you're taking or that your brain's producing is going to be a little bit more effective. It also is inhibitory at NMDA, which is glutamatergic. So just like when we were talking about phenobarb, this is doing kind of a subtle but double duty in terms of correcting the two major neuroadaptations that we see in folks who are dependent on alcohol. It's helping to bolster their GABA that they've downregulated and to lower the glutamate they've upregulated. Okay, so we speculate that after someone has gone through withdrawal and they're left with some of these kind of persisting neuroadaptive changes, acamprosate helps to kind of restore them to a normal balance. That's the theory here. So most of the studies with acamprosate are done on folks who have already gone through detox and then they're started on it. That doesn't mean you have to wait for them to detox to start it, but know that that's what the evidence base is really based on. So a few things to know about the clinical use of acamprosate that are interesting. First of all, totally harmless with the liver. So if you have a patient who you're really concerned about their liver function, even to the point that, I tried to reassure you to not be too worried about naltrexone, but you're past that point, you don't have to worry at all with acamprosate. It is renally excreted, so you do have to check kidney function for these folks. The main side effect that you want to counsel patients about is GI. So they can get diarrhea from this. Unfortunately, unlike with like SSRIs, this doesn't always improve with time. I usually will encourage patients to try to wait it out, but it seems like if they are sensitive to the side effect, this might continue as they continue taking the medication. A weird fact about this that does come up sometimes is that it only comes in one dose. So it's 666. And I have had some patients like balk at this because this is like the number of the beast, or it's associated with Satan. So just be aware, this is the only dose it comes in. If it's more palatable, tell the patient that they're taking 2 tablets of 333. It sounds funny, but I have had this come up before. And then finally, because of the short half-life, it does have to be taken 3 times a day, and that can be a real pain for folks. very quickly, this graph is just looking at a really strong double-blinded randomized placebo-controlled trial. They followed patients after they went through detox. And the takeaway here is that these folks did better on all outcomes of drinking when they were on the acamprosate as opposed to placebo. So I'm going to kind of breeze through this because I want to make sure we talk about some of the other ones. Here's a meta-analysis, and this is a forest plot, which is a little annoying to read, but basically everything to the right of the 1.0 line is favoring treatment, and you can see that this kind of meta-analysis is favoring treatment with acamprosate. Okay, so let's talk about gabapentin. We've gone through our 3 FDA-approved medications. I want to make sure we highlight the most important of the non-FDA approved one, and that's gabapentin. So a few facts about gabapentin. It's structurally related to GABA. That's why it's called gabapentin. Don't get fooled into thinking that it is GABA or that it's a direct GABA agonist. It's not. It's a calcium channel modulator. So don't think that you're giving someone GABA back when you give them gabapentin. In alcohol use disorder, we target a dose of 600 milligrams 3 times a day. It's generally really well tolerated. It's safe to take while the patients are actively drinking. The only risk you worry about is there are some, risks of oversedation, especially in older patients. It is also renally excreted, so you want to check renal function. In Washington State, it's not controlled. To my knowledge, there's only 5 states where it is. It's like Alabama, Mississippi, and a couple other southern ones. So you don't need to worry about jumping through any hoops to prescribe it here. In really low risk of abuse, it's not really something we think about. You may be thinking at this point, I mentioned, hey, 3 times a day dosing, that was a problem with acamprosate. Isn't that going to be a problem with gabapentin? And the answer is yes. If you're really smart, you might know that gabapentin has an extended release version. And so you might wonder why we can't just get away with giving folks the extended release version of gabapentin, which I think is called Horizont. I've never actually seen it used. Big picture, it doesn't work. So there was a really kind of big randomized double-blinded study where they used the extended release gabapentin and they found no improvement in any alcohol-related outcome. The speculation behind this was they thought that the alcohol itself actually impacted the absorption of the extended release gabapentin, and it may actually have converted some of it to instant release, which affected the overall kind of area under the curve, to go back to pharmacology. Big takeaway here is you can't use extended release. The only one with evidence is instant release, and then you're kind of facing this 3 times a day dosing, but patients generally tolerate it well. Okay, let's see if we can do this. So real quick, this is back to talking about instant release, not extended release gabapentin. This is a study from JAMA in 2014. Basically, they did a 12-week double-blind placebo-controlled randomized trial. So we're back talking about really strong evidence. Looked at 150 patients who met criteria for alcohol use disorder. They looked at some typical alcohol-related endpoints, so abstinence and heavy drinking. In both these graphs, the bolded line is the highest dose of gabapentin, which is the one we use. And you can just see across the board better results with gabapentin than with the lower dose gabapentin or with placebo. Okay, continuing on with like the basic outcomes they looked at. They also looked at rates of not heavy drinking and also complete abstinence. Takeaway is that the higher dose of gabapentin was better for both of these two. Finally, they also included some really interesting endpoints. So they looked at reduction in craving. You can see an across the board improvement in the high dose. They looked at sleep quality. So sleep quality improved with the high dose gabapentin. This circles back to when we were talking about, this combination naltrexone gabapentin. Why are these patients doing better a few weeks after detox? So when patients are dependent on alcohol, their sleep architecture is super disrupted. And actually, they can have a period of time that can last for several weeks after acute withdrawal called protracted withdrawal, where their sleep is really bad, they're irritable, and their mood is low. And it's thought that gabapentin, of all the meds we've talked about, is the best one at kind of helping to treat this protracted withdrawal. I think it's easy to imagine how if you detoxed and suddenly you can't sleep and you're unhappy and your mood is like generally low, then that could contribute to you returning to use. So it kind of makes sense if gabapentin helps that it can help prevent people returning to use. And this is actually corroborated by information from EEGs performed on folks while they're asleep, where you can see that their sleep architecture returns to normal on gabapentin, which you don't see with some of the other medications that we take. Okay, so we've gone through the greatest hits for relapse prevention. Now we're going to start talking about some of the more esoteric ones, and I'll see if I can fit this in the next 5 minutes. So of the more esoteric ones, Topamax is the one to know about. It enhances GABA A, works at a non-benzodiazepine site, also works on glutamate. There are a few studies that show it's actually effective. The problem is patients can't tolerate it. So the mnemonic, of course, for Topamax is Dopamax, causes significant cognitive impairment, also makes patients really irritable. It can impact their appetite too. So my takeaway for this is it works, but patients don't like it. So you can turn to it if you tried everything else, but often patients aren't going to tolerate it. Okay. Carbamazepine and valproic acid, a little bit of data showing they might be helpful. I'll just cut to the chase. In clinical practice, neither of these are ever used for alcohol relapse prevention, but just know that there's a little bit of evidence that sometimes they're helpful. With valproic acid, it's speculated this might be related to its mood stabilizing properties. Obviously, it's widely used in bipolar affective disorder. And last and least is zonisamide, which we never use, but does show a little bit of improvement in terms of abstinence rate, time to first drink, heavy drinking days, and drinks per heavy drinking day. But same problem that you see with topiramate, where it has really bad cognitive side effects. The rest of the anticonvulsants have such little evidence that they're not even worth mentioning, and I'm not going to mention them. So to summarize, alcohol relapse prevention, we have 3 FDA-approved medications. Naltrexone is the one you're going to be most familiar with. It's very effective. Don't worry too much about the way it interacts with the liver. And remember that you can combine it with other medications to good effect. Acamprosate is our next one. Remember that it's effective in kind of restoring some of this neuroadaptation that occurs in folks who are dependent. It can cause pretty bad GI side effects, and you have to get over the 3 times a day dosing, but it's totally safe for the liver. And then last and maybe least is disulfiram, which think of as potentially being a behavioral rather than a medication intervention. Consider if maybe, you know, for the right patient who's motivated, has a supportive partner who can do observed dosing, this could potentially be the medication of all the ones we talked about with the largest effect size. So don't poo-poo it. Of the 3 that are FDA approved, this is the one that you want to pay close attention to their liver with, okay? As far as off-label treatments go, gabapentin is the absolute king. It's the one that has the most evidence and is most well tolerated. You can also think about topiramate. It works too, but patients don't like it. The rest of them, there's a little bit of evidence, but they're not widely used. Okay, wow. We just went through a lot of meds, and it's 3:58, so I think I nailed it. But any questions? Because I know that's like a ton of information. And you guys are always welcome to like reach out to me offline or, you know, send me a message on Teams or an email. But any questions on this marathon that we just ran together?
First of all, David, thanks. And that was great. That was really helpful. You got through it. That's really cool. And I wanted to ask about like liver monitoring, hepatic monitoring for naltrexone. So I've gotten LFTs like I think it was like 4 or 8 weeks after starting naltrexone in primary care and in outpatient psychiatry. Is that even actually necessary? I've seen like maybe one thing about it on Up to Date, but do you even need to do that then?
Yeah. So good question. I wish I could stop the recording so we could talk off the record here for a moment. Really, you're supposed to do that, but it's I think clinically in terms of what's going to happen to the patient, it's really unlikely that there's going to be any significant liver injury. So like the best data we have says that less than 1% of patients are going to have any amount of liver injury, and that's liver injury with quotations. It's like a non-symptomatic elevation in their transaminases that has no effect on their liver function, is time limited, and goes away even if you continue treatment. So you should follow the guidelines, to dot your I's and cross your T's. But if you're, for example, trying to make a decision about whether or not to start naltrexone with a patient who historically is terrible about following up, and you're worried that they're not going to be able to get labs, my recommendation would be, don't let that be a reason to not give them naltrexone. So, don't be so strict about the recommendations for monitoring that you avoid what's maybe the most effective medication we have. But do your due diligence and order the labs and follow them. Don't expect that there's going to be a clinically significant change with that. That would be kind of my takeaway for it.
Cool. Thank you very much.
Yeah, of course. Good question. Anyone else with any questions? It's a lot of info.
Any like guidance as far as like titration up on gabapentin is easy. What about tapering down as far as duration? And yeah, guidance on like actually getting people off it, especially if they've been on it for a significant amount of time.
Yeah, so you should taper it. Usually, if someone's been on 600 milligrams TID, it depends on the clinical setting. Like if they're acutely delirious and they're inpatients and we think it's contributing, we'll stop it just immediately and monitor them. If you're talking about more like outpatient, I'll kind of just go as they tolerate it. So you could pretty easily and quickly go from 600 milligrams TID, in my opinion, to straight to 300 milligrams TID and not have a problem. If the patient told you that they were feeling a rebound in their anxiety or whatnot, you could play around with the dose a little bit and bring one of them back up to 600 or two of them. In my experience, folks tolerate a pretty quick titration off of the medication. And I've not had too many people tell me that they had a really bad like rebound anxiety or became tremulous or things like that, the way that you definitely do see with benzodiazepines. So, in terms of best practice, I would say a slow titration over weeks is what you should be doing, and you should knock down 300 milligrams from one of the doses, see how they tolerate it. In terms of like reality and what I've seen people tolerate, you can pretty quickly go down off the doses. So switch them from 600 TID to 300, or go from 600 TID to 600 BID. I generally see people tolerate it really well, and in the acute setting, we will very quickly pull people off and not see much in the way of a problem. Yeah, gabapentin's great, and when I was a psychiatry resident, we all poo-pooed it because it has so many off-label indications that we would joke that really it must not be useful for anything and it's a placebo. And I've done a complete 180 after doing my fellowship, and really, I've seen patients withdrawing from alcohol respond to gabapentin. You really see that it's well tolerated and efficacious. So definitely, I advise you guys to get some practice prescribing it. Cool, good questions. Anything else? All right. Well, hey, thanks for staying tuned with me, guys, for the 2-hour-long session. If any questions come up later, let me know. I will be emailing out my slides, so you'll have access to them, and I'm always available to chat. So reach out if you have questions, okay? Hope you guys have a great afternoon.
Thank you.
See ya.
Thank you.